My pleasure to hand over to the National Clinical Lead for Deterioration for NHS England, Dr. Inada Kim, who's going to talk to us about the single language of sickness and deterioration and the COVID virtual ward. Over to you, Matt.
Thanks, Jake, and hello, everyone. My name's Matt. I'm an acute physician, former GP, and I work on a few national work streams to do with deterioration and COVID. And today's talk is very much one of two halves. Firstly, all-cause deterioration and what is happening outside of the prisons world in that regard. And then something more on COVID assessment management and addressing some of the very well-made points that Trina just mentioned. So from an all-cause deterioration perspective, my career has been plagued with a Tower of Babel type situation in all the environments I've ever worked in. Namely that we work pretty well within our silos in the sense of people know what to do, they know how to act. But as soon as the patient crosses that interface and goes into a different silo, all hell breaks loose. And often the communications between silos or between time periods and shift handovers leave a lot to be desired, leading to the highest cause of root cause of harm events across the NHS, namely communication errors. Usually assessment related, to do with the continuum of care, and in some ways to do with the way organisations function and the way they interact with each other. This is systems thinking on the highest levels. And when you look at the causes of safety incidents in healthcare, and this is a study that looked at the past 10 years worth, what you find is nearly 2/3 of them relate to this concept of deterioration. Deterioration that you can pick up with if you spot the early signs, if you understand the way physiology is changing. And it's led a lot of us to believe that the greatest advance we can make in healthcare is not necessarily a new drug or a new surgery or any new therapy, but actually a change in the way we work as an entire healthcare system. And that's the broad ambition of this. If you look at the activity of the NHS over the past 10 years, what we've noted is not only an increase in terms of emergency admissions, but an absolute increase in the amount of acuity. So people are more complicated and more sick than they've ever been, with more disease processes going on than ever before. We are victims of our own success. We're keeping people alive beyond their sell-by dates in some ways, beyond what we achieved 10 or 20 years ago. It's not an equal playing field. We know in prisons we can do better, we can reach higher, and we know within populations who exist within prisons and also outside with learning disabilities, severe mental illness, they're in much greater prevalence within the prison sector. This is a highly unequal population whose needs need to be addressed urgently, and that urgency needs to reflect on all of us on the call today, in what we do, how we collaborate, and how we bring advocacy to this population group in terms of how their physical health issues are dealt with, because there is room for improvement. So in terms of, I guess, the next stages, we think about deterioration as being the big bad thing that happens to most people before they die or they suffer a cardiac arrest. The number of insults are legion that can cause deterioration. And once you go down that trajectory of all-cause deterioration, you enter a slippery slope, as we call it, whereby if you spot the deterioration early and do things that are remediable at that point, you can prevent the slow descent towards, or sometimes rapid descent towards, death. So it's a matter of what you can do to pick these signs up early. And we know that in 95 cases out of 100, it is a change in physiological vital signs that predicts death very, very well. So the question is how you pick up vital signs, how you pick up the early signal of deterioration in all environments. And that's what we've worked really hard on in the community to address things like diabetes, infection, vascular events, cancer, trauma. And we've done really well within the non-prison settings. The question is how you can extend that to the prisons as well and construct a national SOP around this. It shouldn't be variable. It shouldn't be piecemeal. It shouldn't be prison by prison. This needs to be standardized across all prisons. Obviously, with the advent of COVID, things have changed dramatically again, and the NHS and healthcare has had to be remarkably nimble. And we'll go into that in a minute. There's been a changing demographic in what we see in terms of illness, in terms of hospitals and death. So whereas 10 years ago, cardiovascular diseases were by far and away the most common reason for dying, we've halved this. We've halved it mainly through the intervention of primary care, preventative medicine, and lifestyle changes. So this halving of mortality and deaths from cardiovascular diseases and acute myocardial infarction particularly has not been a victory for mankind. We have not cured death. We never will. So mortality is something we haven't cured. So what has taken up the slack? And what's taken up the slack has been infection, our oldest killer, that now outkills acute myocardial infarction by a factor of 3. And indeed has always been our oldest killer. Not only infection, I guess, from a bacterial perspective, but also if we think about viral, you can almost add another 20,000 deaths per year. And when you add COVID, that's an extra 20 or 30,000. And you can start to see why this is our biggest challenge of all. What we know from health services research is that recurrently there's been an issue of failure to spot deterioration, and that these hard-hitting reports time and time again have told us the same thing. Communication errors, decision making in all settings, delayed management of remediable deterioration, and that communication conspiring to lead to harm events and an increase in cardiac arrest rates. We see the same guilty parties time and time again, monitoring, recognition, particularly with this concept of spotting a sick patient. People don't suddenly deteriorate, we suddenly notice. And that was a euphemism that was first bandied about in deterioration talks 10 years ago, but has remained true to this day. So the question is how we improve our monitoring systems, our recognition, our communication mechanisms across the time periods of healthcare and silos of care, and improve our response times, because this truly is our low-hanging fruit in how we improve health outcomes everywhere. So the single most important consideration, I guess, with deterioration is thinking about the whole pathway in all settings. This concept of monitoring, recognition, escalation, and intervention, because it's the same in all environments, punctuated and brought together with good communication. It's like a reflex arc. When you tap someone's knee reflex, the action thereafter should be a response that presumably or often saves injury. And that's the whole point of a reflex arc after all. That's why we have them. And this model is transplanted to deterioration with the same sort of, I guess, effect. How can we invoke an automated system to ensure that we pick it up early and we act where appropriate? And the thing that conspires against us more often than not is the communication element that links all of those elements together. So what national early warning scores do is it looks at observations, the physiological observations, breathing rate, oxygen levels, whether someone requires oxygen or not, their blood pressure, their pulse rate, their level of consciousness, and the temperature they're in. And when you look at normal and then you add points based on the deflection past normal using that scale, you can predict who's going to die, who's going to survive, and how long they're going to be sick for, and what their chances are in both medical surgical problems and increasingly in all environments. So the large scale studies have kind of proven this, and we compared it against all other scoring systems or early warning scores to find out what was the best, and it won. And that's why we're doing it everywhere now. And what we found in the hospital perspective is that when you analyze hospitals over time, and this is a 10-year study that looked at all acute hospitals in England, we found that actually using this scoring scale resulted in an 8.4% reduction in cardiac arrest rates per year in every single hospital that instituted it against those that didn't. So it's really black and white evidence as to why this is the right thing to do and why we need to take it more seriously. So as a result of that, the 79% of acute trusts became 99.5%, and the 80% of ambulance trusts became 100%. So now it's used everywhere, and that's important. The same language needs to be used everywhere for us to really understand what this has done to hospital mortality, because the number of deaths haven't really changed because the sheer activity and numbers of admissions have just gone crazy in recent years. What we have noticed, however, is a reduction in all-cause mortality, amounting to around 20,000 lives over the past 10 years since the implementation of a standardized language. Now, obviously, it's not that alone that has happened, but it is encouraging early signal. We must also understand that the hospital is not a true reflection of the community. The two are different, and certainly in prisons as well. So whereas in a hospital, our hay bale to spot the needle in the haystack is really, really small and the needle is really large. In the community, the needle is really small and there is a whole bunch of fields all stacked full of hay bales. That's why being in the community is so much more challenging, or a prison. There are differences from a time course of onset of illness, and also the way we monitor, the way we have a continuum of care, and the way that we communicate and escalate. So the two are not identical, but there are similarities. And the early evidence from the community, and this is a paper we published during COVID, so it didn't really get much press, that demonstrates essentially your news score absolutely predicts who's going to die or end up on intensive care when taken in the community at the point of referral. And this is really important. It's not just a score or physiology. It's about the score plus judgment. Clinical judgment is really important here. You cannot ignore them. What we also found is that when you use the score at the referral point as a communication tool to highlight how sick a patient is, more people survive and less people die. And this all needs to be standardized and statistically analyzed when we have the time and funding to do so. But it's really promising early signal of what we really firmly believe: good communication matters. And what we know also from this early evidence is that a normal score is incredibly predictive of those who are going to survive. Again, critical information to help healthcare professionals make that decision in the community. So if your news score is less than 3, and this is data from Portsmouth, then your mortality rate is 0.11%. Pretty staggering, and we've reproduced this all around the world. Normal physiology, high chance of survival. Bad physiology, high chance of death. Important messages to take home, and just how important vital signs are in actually predicting who's going to live and who's going to die. And I guess reasons to why we check blood pressures or pulse rates, why we've done it for hundreds of years, but only now finding the evidence to back it up. So in terms of news scores themselves, we use this to define where we place people in the hospital sector. Low scores in an ambulatory or clinic type setting, high scores in a resuscitation room in the emergency department, and the prioritization and time periods for ambulance pickup as well. So if you can see the benefits of using that language, if you're in a prison, you're waiting for an ambulance, and people don't know how sick a patient is using a standardized score, you can imagine the delays that happen. And we are introducing scoring scales to actually define ambulance response for all sectors. Again, fighting the battle with one hand behind your back in a prison without a news score is not fair for the patient or the system. So this is about ensuring we do the same thing everywhere. And the opportunity here is whether this system could be brought in as a means of monitoring sick potential patients in prisons, because not everyone goes sick immediately. There may be a bit of infection that someone's in sick bay with, a cellulitis, for instance, a bit of antibiotic. But if you can't monitor their physiological response and how they are doing with a score, then it becomes really difficult handing over the continuity of care and whether a patient is genuinely improving or deteriorating over time. We're doing this in learning disabilities as well, and I know how prevalent learning disabilities are within that population. And forming a taxonomy to try and train, I guess, those who are not medically qualified or nursing qualified with what to look out for in terms of the signs of badness before they develop, because we need that signal to understand who needs their physiology measured potentially. And this is some really exciting work we're doing in the community with learning disability patients that will, we hope, soon be validated to produce an early warning score of symptoms, to know what we should look out for in those who are untrained, so that they can spot things early and ensure that people get assessments in a timely manner. So we are big fans of Restore 2, which just won the Health Service Journal Award for deterioration and has won 2 other awards this year, that looks at recognizing those soft signs of deterioration early, the normal things that normal people notice in terms of symptoms, an observation chart to record observations and physiology to predict death or bad outcomes, or indeed to demonstrate recovery, and then a plan for what you do based on the patient and the escalation plan that's been agreed in an easy to use format with a communications template to ensure that everyone involved in that patient's cares knows what has been communicated and decided at all care settings. And this has all been backed up with educational resources and e-learning resources that are all available for free on YouTube. How you manage patients and spot early deterioration and then escalate based on this to try and promote a single unified mental model of deterioration. Apps have been produced to back this up as well. They're all free. My favorite is the respiratory rate app that you tap when someone breathes and it gives you a score of respiratory rate, because I'm terrible at counting it. And then this RCP app that's really good, and it covers primary care in the community as well really nicely. We're moving towards standardization of referral forms in from the community in all settings as well. We hope this will be electronic in due course. So again, standardize that communications framework and pull where we can pull, because it comes back to what we started with. The next great advance in healthcare is not going to be a cure, but the change in the way we work as a system. And this is our opportunity to improve the way we prioritize patients, plan, prepare, and place them appropriately, monitor and survey those at most risk. And the question for all of you today is whether we should and could implement this strategy across the whole of prisons healthcare, how we go about this, and how we do it in one fell swoop instead of in bite-sized chunks in piecemeal, because that might work for that particular region, but the potential gains are too large for the whole of the healthcare system. So that covers the deterioration element. And what I'd really like to talk about now is the response to COVID and the virtual ward, if you don't mind. So thank you for staying. So what we noted during first peak with COVID, and I work as an acute physician, large shifts in the emergency department, was that we currently saw people with really low oxygen levels arriving in a heap, 60%, 70% SATs, often an absence of symptoms of breathlessness. And this was not an unusual story. This concept of silent hypoxia was born based on it, well reported by the media. And it drew increasingly a lot of us to believe that this was about our community response as a result. It's not about the number of ventilators or intensive care beds that's going to save people's lives. It's about getting people in early enough to save them with the right interventions, including early oxygen treatment, which really does help. We know from first peak the UK could have done a hell of a lot better with its case fatality rate with COVID. We had a very low oxygen level rating. For before a patient came into hospital, they had to trigger quite low oxygen levels. Maybe we overprotected the NHS is one question. Against countries that were more developed around the world that had lower mortality rates, that admitted people with a higher oxygen level. And, you know, this is a lesson from first peak. We need to listen proud and learn proud about this. We need to learn from history of what happened in 1918 with Spanish flu, where the great death rates happened in second peak, not first peak. And we are in second peak now. So the question is what we do as a system to empower our patients, our carers, and our health systems in the community to escalate early and potentially save lives. And the question again, like News 2, is why not in prisons? Why not? This is not too difficult. This is achievable and doable. This is within our gift and surely what we need to aspire towards. So the evidence for importance of oxygen saturations has led to us putting these lines in the sand in terms of oxygen levels and what you do with them. 92% or below, you need to be in hospital if that's new for you. 93 to 94, you may well need to be in hospital. You probably need a hospital assessment with a chest x-ray, blood tests, including a D-dimer CRP, and an exercise test to see if you drop. And 95 to 100 being normal. So this safety netting guidance is about to be fully published and translated into all languages. And the question is whether we can develop a prisons-based pathway based on this emerging evidence. We published this paper recently. It was picked up by the Mail, Telegraph and Times since, because I guess it speaks to what people have noted. Namely, even relatively low normal oxygen saturations are associated with an increased mortality rate with COVID. And it seems to be quite avidly taken up by the medical fraternity, with 82,500 reads of this paper within 2 weeks. So it's important to take on the evidence of what this involves, but it's also important to consider the impact of what that will have on services. The how for COVID and what we need to do to improve our outcomes ensures aligning our pathways and ensuring we develop a proper functioning prisons pathway group that knows about this evidence and that is linked in with our national efforts on COVID in all other settings. You cannot do this in silos. And that we ensure we build a sensitive system that uses remote assessment where possible and continues this concept of the virtual ward, which is that monitoring of patients most at risk of bad outcomes and dying from COVID at home with an oxygen saturation meter and a diary in all settings. The safety netting therein, digital supporting texts and apps, the evaluation to prove the model works, and then the scale and spread across the whole of England. And we have active mechanisms for trying to achieve this. So the pathway itself is pretty simple. Wherever you are, you need a test, you need COVID assessment, risk factors, you need an oxygen level reading. You need to not forget about non-COVID. It's not just about COVID, it's also about all other causes of deterioration. And if you go down the route of suspecting COVID and you're not admitted to hospital, then you enter the at-home model for COVID. If you're high risk, you go down the virtual ward, which is this enhanced monitoring involving oxygen saturations and a diary for at-risk patients. And if you're in the lower risk category, if you're younger, then you have more passive follow-up with safety netting, remembering early threshold for oxygen level readings where appropriate, because sometimes it's just the oxygen level that dips, and sometimes it's the only signal that someone might die. In terms of the pathways themselves, we've aligned emergency department care homes, domiciliary care, primary care, and the virtual ward pathway. So if you're high risk and you're not admitted through those pathways, you go into the virtual ward pathway. From a primary care perspective, it looks like this, so that at the triage point, you don't forget about non-COVID. If you are going down the COVID line, you're categorized into mild, moderate, and severe based on your oxygen levels and your symptoms. We know from large-scale multinational studies during first peak that breathlessness, myalgia, chills, severe fatigue, and delirium most predicted who was going to die from COVID from a symptom perspective. And the anosmia and loss of taste is not that predictive, which we know it predicts who's got COVID, but it doesn't predict who's going to die. And that's what we need to know. Who's going to die, who's at most risk, and who needs the oxygen level monitoring on a regular basis. If you end up not being admitted, and you have relatively normal oxygen levels, we do exercise tests on everyone, walk them for at least 40 steps on the spot or around a room, or do a sit to stand test for a minute to see if they drop. Again, highly predictive of bad outcomes in COVID and indeed of the diagnosis, because COVID causes a VQ mismatch pneumonitis in your lungs, akin to PJP or PCP and AIDS. So what that does is it means that if you drop when you exercise or you do things, then it's highly predictive of COVID and it's highly predictive of bad outcomes. And I do it on every patient I'm keeping at home or sending home. You know, we always do this. We test people by walking them. There's emerging evidence that there's a bloody good reason why we do it. And in terms of the monitoring in the virtual ward, this all is in the realms of personalised care. You don't make these decisions without thinking about what is best for the patient or their views. Shared decision making, both in terms of escalation and sometimes palliation. And personalised care is very much the fore in this strategy as a result. You need to get this right, not only in primary care, in prisons, in care homes or domiciliary care, but also in hospitals, to try and make sure we admit the right sort of patients to hospital early enough, and we expedite discharge where that's appropriate and keep people in where it's not appropriate. We know we over-admitted people with normal oxygen saturations during first peak, partly out of fear. We can't afford to do that again. Not in second peak, not with the projections of numbers we are seeing. We've got to get it right. And what's right is getting people in who start to desaturate, who are at high risk of mortality, and keeping a close eye on those who haven't, and watching for the early desaturation where possible. These systems take minimal amounts of time to set up. There's a ton of resources already produced and out there. The record so far is 57 minutes from deciding I want to set one of these clinics up to implementing it. This is not unreachable stuff. This is not unachievable. We've bought 700,000 oximeters to allow this model. There's no reason why we can't implement this across all prisons in this country. In terms of the what here and the monitoring, so the inclusion criteria at the moment from a risk category appears to be 65 or above, diagnosis of suspected or proven COVID and symptoms. That line may change over time based on our evidence, but the evidence so far suggests you're pretty unlucky if you die under the age of 65 without comorbidities. So it makes sense to go for that. But judgment is paramount here. And if you're a clinician and you're worried about a patient, you put them on the virtual ward if you're worried. End of story. Clinical judgment is paramount here. And we will ignore that at our perils. So within the monitoring elements of the virtual ward, they're monitored at the crisis points we have found from an evidence point of view within COVID, which is days 2, 5, 7, 10, 12 post onset of symptoms. Death most often is preceded by a symptom change within days 6 to 10. So that's our heavy period where we like to have monitoring and feedback. Early results from this approach are quite staggering, with a 1% mortality rate from 1,800 patients. That's amazing, I think, in terms of our previous models. So the resources that have already been produced, including safety netting, a COVID diary, the oximeters, obviously, an animation to help patients translate it into all different languages, and also help those not trained with how to use an oximeter and what the bad signs of COVID are to look out for, apps and interoperable digital systems that are in the pipeline, all stuff out there that's available for free. We've done this across populations, and in my particular patch, a 600,000 population involving an ambulance trust, all the care homes, an entire hospital's SDEX, and 2 community hot hubs looking after about 600,000 population in entirety. Question is whether we can also add prisons in every single one of these 150 business development units as run by academic health science networks. And it's getting it right to do the metrics to prove that this makes a difference, that we can keep people that need to be kept at home under close surveillance. And we can produce a 24/7 monitoring service to ensure that we pick up early deterioration in this population and standardize how we manage things. This should not be a postcode lottery. This should not be a lottery based on health inequalities that plague us. We need to get this right, and we need to get this fair and equitable for all populations, not just those who have a voice, who are white and who have no other inequalities. So this is really important stuff. The update now is that we've been given roughly £150 million from a primary care perspective to get this up and running, and to also think about the health needs of vulnerable patients and particularly learning disabilities. 3 of those 7 requirements from that £150 million spend addresses people in our population that we're talking about today. This is our opportunity. Educational resources have been produced to think about every stage of competency required for this COVID at home model, namely the referral, the triage, the onboarding, the monitoring, and then the recovery and discharge phases. And free resources have been produced by the Health Service Journal that are available on that link that enable you to access training resources for anyone requiring a bit of knowledge about COVID, but also how to monitor and spot early COVID deterioration and do something about it. It also covers a bit about Restore 2 and all-cause deterioration as well. So our next steps as a country are to reflect on the fact this has come about through collaboration and working together. The fact that we probably have our clinical model in all areas except prisons now, and that the implementation, which is going to be carried out by HSNs, is there to help in every single one of our regions. We need a coordinated national plan going forward, though. The funding has pretty much been agreed. Our evaluation is underway, and our learning points from First Peak need to be held in our minds going forward. Namely, this is about collaboration. No one size fits all. Don't wait for perfection, because it's the enemy of the good. And there are a variety of different models that will save people's lives with COVID in all environments. The monitoring itself does not have to be carried out by senior GPs or hospital consultants or nurses. This is something that can be done by lower banded people and by patients themselves. There's a lot of resources out there, and we are well on the way to minimizing the outcomes we hope to reduce and optimizing the safety and quality of care for people in all environments. So thank you very much for listening, and I'm delighted to take questions electronically in due course.
Thank you very much. Thank you indeed, Matt. That was an incredibly profound and impassioned talk. Deteriorating health lead. So I think we all recognise that detecting deteriorating health in the people of prison is an important focus that needs further development, whether we're talking about COVID or just generally. So thank you very much for that. We do have a minute or two of time before the end of the day. If it's possible, we could perhaps have a question. I don't know whether, Matt, you're able to field some questions from the chat side for Matt. Matt Snape. Or Ria.
Hi, Jake. So we've got just some praise. Just wow, absolutely brilliant, Matt. And then one of the questions from the book. With Knott's Healthcare, our 8 prisons and IRC have been using new S2, and prior to the news scores, all staff receive training, and this and it's form part of the annual life support indicating sepsis awareness.
That's fantastic news. It'd be amazing to do a case study, wouldn't it? If there's anything published on the effect of that, both in terms of, I guess, outcomes, but also staff perception and maybe patient perception of whether it's made a difference.
Just more praise again. That was fantastic, no question.
All right, thank you very much, Matt. Well, I'm going to conclude the day there, and thank you again, Matt, Inada Kim, for your talk this afternoon, and for Trina Lenahan's talk prior to that. So this now concludes our second day of the virtual summit. We've now heard from 40 speakers across the 2 days, and somewhere in the region of 200 attendees, 220 attendees. I don't know about you, but I've been hugely uplifted by the interest and the enthusiasm generated by the speakers and the attendees across these 2 days. For me, it has been great to break out of my day job and spend a couple of days and connect with everyone. Importantly, it's been useful to hear and see the work and thinking of others in parallel. And it's allowed an important means of observation and reflection on my own practice. And I hope this has been your experience too. It's certainly been an extraordinary demonstration of the innovation, passion and skill and expertise in healthcare and secure environments. And this will be our last opportunity to come together this year, and I really hope we can meet face to face next year. We hopefully at the 8th Health and Justice Summit, and if we can't bring that forwards to you in March, then we will try and hold another virtual event sometime in the new year, and as I say, maybe move the face-to-face event to November next year. I can hear Matt's team crying at the thought of it. With that, it remains only for me to thank again our speakers, to you, the audience, and of course our sponsors, NHS England, Camurus, Ethifarm, locum.co.uk and Practice Plus Group. And of course, I would normally bring Dan and his team out at this stage to the event to thank them and for them to accept a round of applause. Okay, so I don't get to do that on this occasion, but I must name them. The team have worked hard and gone to extraordinary lengths to ensure the technology in the IT has enabled us to come together in this way. A virtual round of applause, please, for Ria Akine, Matthew Snape, Sean McLaughlin, Callum Ashall, Laura Jones, Kelly Cullen and Sarah Harrison, not to mention Dan Snape himself. So on that note, and it is with sadness I'm closing our first virtual RCGP Secure Environments Health and Justice Summit. And as we head towards Christmas and New Year, I wish you all well. I've no doubt that 2021 will bring its own challenges and opportunities, and I look forward to meeting again at our next summit. Good evening.